Good afternoon, everyone. Welcome to the System Care Learning Series. My name is Lee Taylor, and I'm going to go over a few things before we get started. Our session today is in Zoom webinar. That means that all attendees are muted and your videos are off. We are recording the session and it will be available soon. I will post the link again in the chat box here in a minute. Please use the Q&A feature at the bottom of your screen for any questions. We will have time for questions and answers at the end of the presentation. We do not have interpreters with us here today, but you should see the live captioning. And if you don't, press the CC button at the bottom of your screen. We probably will have some technical difficulties today, so we appreciate your patience and grace for any that we encounter. Okay, certificates of attendance or certificates for CEUs. To be eligible, you must be in the content portion of the webinar for at least 90% of the session, and this is a mandate by the boards. Please do not leave the webinar until the conclusion of the Q&A, as that counts as part of the session. You do not have to enter your contact information in the chat, as attendees and their time is tracked by Zoom. You must register for each session using the same email address, and you must join with the link that was emailed to you. If you receive the link from a friend or coworker, we will not be able to track your attendance and you will not be eligible for a certificate. And the same email address is used throughout the System of Care Learning series, and that's our unique identifier used to track attendance. By April 3rd, you will receive an email from me with a link to access the session evaluation, then your certificate. This is a screenshot to show the landing page for the evaluations and certificates. You must complete the session evaluation to proceed to the certificate. And lastly, you are responsible for printing your own certificate. We do not mail or email those. This website houses several years of the System of Care Academy, so if you lose your certificate, you can access this website to print it anytime. And now let's meet our presenter. Jody Jaggers has served as the Director of Pharmacy Public Health Programs at the Kentucky Pharmacists Association since October of 2018, and the Director of Pharmacy Emergency Preparedness from April 2017 to October of 2018. He is responsible for the operations of Kentucky's Mobile Harm Reduction Pharmacy via the Opioid Data to Action grant, as well as distribution of naloxone through the Kentucky Opioid Response Effort, which we also call CORE, as well as naloxone distribution to law enforcement agencies across the state as part of the funding from the Kentucky Office of Drug Control Policy. Prior to joining KPHA, Dr. Jaggers worked 13 years as a community pharmacist in both chain and independent pharmacy settings with experience as a staff pharmacist and pharmacy manager. He completed his undergraduate degree at Western Kentucky University in 2000 and his Doctor of Pharmacy at the University of Kentucky in 2005. Welcome, Jody.
Hey, thank you for the warm welcome. Let me share my screen for you all. Can you hear me okay, Lee? Thumbs up? Okay. Hey, so I am Jody Jaggers. I'm a pharmacist with the Kentucky Pharmacists Association, and I don't normally do this, but something just kind of, I wanted to share this with you all because anytime I have a large audience, I feel like sometimes hearing somebody's story is important. I've never struggled with substance use disorder or anything like that, but I do have a story I think that is relevant and hopefully might be helpful and encourage some of you. My time as an independent pharmacist and a chain pharmacist, I used to be one of those medical professionals that very much spoke in stigmatizing language, very much was not a fan of dealing with folks that struggle with addiction, that struggle with substance use disorder. I called people junkies and crackheads and didn't want to sell needles, didn't want to fool with Suboxone. All that was me. And I really had a complete 180 in the way I look at substance use disorder and people in general. And it kind of started with my church. We actually had some families in our church, one in particular that shared their struggles with their child with substance use disorder. And it really crystallized for me that this affects everyone. that this is not something that is just those folks, that those people, those other people there. This was a family that I'd never in a million years would have imagined would have struggled with this. And so it really started to have me think differently about people, just and look at them through, for me, through my Christian worldview, through that lens. But it's basically created a 180 for me in how I think about folks, how I think about substance use disorder, and how I talk to people about it. And so I share that just to know that, one, that is still out there, that there are still medical professionals and other providers that still struggle with stigma, that still have their hangups, that still maybe aren't really on the spectrum, or not as far along the spectrum of how they integrate care there. And so I want you all to know that you're going to interact with those folks if you haven't already, but also know that, like, people that struggle with addiction, that struggle with substance disorder, they recover. We know people recover. People that have stigma and that have different philosophies and things can also change and can be rehabilitated themselves. And so I am evidence of that. So I just want to share that with you all. Like I said, I don't usually do that, but it's one of those things that just kind of hit me that, you know what, I feel like it might help people understand where I'm coming from. And so with that, we're going to jump right in. Today, I'm going to talk to you primarily about just opioid overdose response, recognition response, a little bit about prevention. But we're going to primarily talk about naloxone and how you use it. We'll hit a few other things in there, though. I talked to Lee, and I think most of the questions we're going to save for the end. However, if you have something that's really a pressing question, I'm okay with being interrupted. So if Lee needs to interrupt me and say, hey, we've got some questions, there's one spot in particular that I'm going to pause to field questions because I think it might generate some, and I want to make sure that we have all those answered and everybody feels good before we move forward. But we're going to talk about some stuff that's probably old hat to you. We're just going to go over like what opioids are, what naloxone is, and what overdose is, who's at risk, how you reduce that risk, how you recognize an overdose, and then how you respond to an overdose. We're going to briefly touch on Good Samaritan law. We're definitely going to talk about naloxone nasal spray, but not just the nasal spray. We're also going to talk a little bit about the other dosage forms of naloxone that are out there. And I'll show a brief demonstration on those as well, on how to utilize those, because there are some new products. And we're also going to just go over probably some of the most up-to-date stuff, and that's the over-the-counter status of naloxone, which some of you all probably have questions about. I'm sure you've been hearing about it in the news. I'm going to turn off my video for the moment, just because I don't want there to be any bandwidth issues. And honestly, looking at me is not going to be all that interesting for most of this. So I want you to be able to focus on the slides. And then again, if you have questions, put them in the Q&A. And Lee, if there's anything you see that you feel like really needs to be asked right now, go ahead and unmute yourself and interrupt me. That's totally okay. So we are going to jump in here with what are opioids. This is something I suspect everybody's pretty familiar with. Opioids are a class of chemicals that work on receptors in the brain. They block the body's ability to perceive pain. Now, right off the bat, I want to just mention something. Opioids are not in and of themselves evil. They are not bad. They are a tool. They are a tool like most other tools in medicine. And when used appropriately, they can be wonderful. If you've ever had a surgery, if you've ever had chronic pain issues, if you've ever had anything, you've probably experienced the benefit of opioids, especially on a short-term level, but even long-term people use them. I mention that just because so many times now, especially, both medical providers and the public look at opioids and they're scared of them, and understandably and rightly in some ways. But again, when used appropriately, they're not bad. Okay, so they're not evil. They're not inherently bad. People that use opioids are not bad or evil or foolish. So just keep that in mind, whether it's they use them under prescription or whether they use them illicitly. So these are just things you'll need to, like I said, this is probably preaching to the choir here, but I just like to throw that out there anytime I do a training. But how do they work? So, this is kind of an abstract concept. So when you think receptors in the brain, and I try to stay away from branded stuff, just so you know, but, because I don't promote any one product, but, naloxone, Narcan had a helpful little image here. Receptors in the brain, I try to, on a very basic level, describe them as the ignition to your car. And opioids are like the key to the ignition. And when opioids attach to the opioid receptors, they turn the key to the ignition on, and that's what activates those receptors. So opioids are opioid receptor agonists, meaning they activate them. And so when you turn the key to your car, the engine comes on, and then all the stuff, if you had your radio on, if you had your air conditioning on, all that stuff starts happening. Same concept with opioids. They're very useful, both chronic and acute pain. The issue is that they work in the same part of the brain that controls breathing. And so, if you've ever used opioids, you're probably familiar with some of the different side effects. They're going to, cause you not feel pain. They may make you feel sleepy. Some people, they make feel jittery depending on the opioid. Some of them, you may have a foggy brain. Maybe you're not sleepy, but they just cause like brain fog. So they cause a lot of different things, cause constipation. These are all, again, part of a result of putting the key in the ignition, turning the ignition on. The brain, where the breathing center is, this is where the problem is. It's a twofold problem. They are highly addictive, which we know. We kind of forgot that and lost our minds a little bit back in the late 90s, early 2000s, with stuff that we knew was always the case, but there's always been this desire to find the perfect opioid that is non-addictive, but still treats pain. And so far as we know, we've not found that. So when you have too many opioids in the brain, basically you forget to breathe. Your body stops breathing. And this is where people succumb to opioid overdose. As your brain loses oxygen and ultimately dies, the rest of the body goes with it. And so that is what will cause somebody to succumb in an opioid overdose, is the lack of breathing. So this is kind of just a reminder for those of you. I don't know if there's very many clinical folks on here, but even if you're not, some of these names probably look familiar. These are common trade and generic names of opioids. The most common one that people are going to recognize are hydrocodone and its various brand names: Vicodin, Lorcet, Lortab, Norco, and then oxycodone, Percocet, OxyContin. Those are probably the ones that most people are familiar with. I like to draw people's attention, and we're gonna camp on this for a few minutes anyway. Fentanyl, and fentanyl is an opioid. It's 100% synthetic. It comes as a prescription product. Primarily, Duragesic is the name of that. It's a patch that was developed years ago. Can be worn for 72 hours, 48 to 72 hours, and it slowly pushes the drug through the skin through a very specific matrix that was developed in a lab. So it is an opioid. This is one you're familiar with. Some people don't realize that it is a prescription, so I do want to make that clear that there are prescription versions of this. And then also you'll see down at the bottom, heroin and carfentanil. Heroin is not a non-issue, but in Kentucky, heroin was really a thing a decade ago, really, and before. Now, heroin is not as common in Kentucky, and pretty much everything that's marketed as heroin is fentanyl, and we will get into that here in a little bit. Carfentanil, you've heard about. This is my opinion, and so take it as such. But from what I've seen and what I've read, carfentanil is kind of the boogeyman. It is out there, but I don't think that it is out there as commonly as what sometimes reports will suggest. It is a veterinary grade opioid, and think large animal tranquilizer like horses, elephants, things like that. Like carfentanil is used in large animal veterinary medicine. It does not have any human applications, but it is like a cousin of fentanyl as far as the way it's created. So let's talk about fentanyl, because this is everywhere. You can't look at the news, you can't talk to people without hearing about fentanyl. Some facts: it is 100% synthetic. It's 50 times stronger than heroin and 100 times stronger than morphine. It's dosed in micrograms. If you are a math person at all, micrograms is really small amount. Okay, so most drugs that you're used to are dosed in milligrams or even grams, and so microgram, you're talking thousands of fold difference in these. And so what that means functionally is that it does not take much fentanyl to be therapeutic, and it does not take much more fentanyl to be toxic. Okay. So you've all seen the picture of the little tube that has what looks like a grain of sand in it, and this is how much fentanyl it takes to be lethal. And that is accurate. The part of that is not super accurate is that, one, it does have to be ingested or injected. And again, we'll talk about that in a little bit. But know that it's potent, know that it is one of the most potent ones that's out there that we see commonly, but that it does have legitimate uses. There's pharmaceutical fentanyl, which we've talked about, Duragesic, and then there's a couple other name brands, Actique and Sublamaze. What you're hearing about in the news, what you're reading about, what all these reports, though, are not referring to the pharmaceutical fentanyl. They're referring to illicitly manufactured fentanyl. Now, you may still have folks that you encounter that abuse pharmaceutical fentanyl. People will take and they'll get duragesic patches and they'll cut them into squares and they'll park them in their cheek. If you can imagine the medication side, they'll put it in their mouth, park it in their cheek, and they'll absorb the medication that way. And it goes much faster because your mucous membranes in your mouth definitely absorb things much faster than your skin would. And so people do still abuse that when they can get a hold of them. However, that is not what's driving this current news, spate of news reports, the current spate of overdoses in Kentucky and across the country. Illicitly manufactured fentanyl is similar to fentanyl, pharmaceutical fentanyl, but they are not identical. As a matter of fact, if you know anything about chemistry, you can add different groups onto a baseline chemical structure, a core structure. And every time you add a group, you slightly change what that compound is. And so fentanyl kind of speaks to the parent compound, but folks all around the world, these different drug dealers, different cartels, they sometimes accidentally, sometimes intentionally will play around and they'll add different groups just to see what happens. Some of it is because this illicitly manufactured fentanyl, since it doesn't have classifications, it's not technically classified as Schedule 2 because it's not on any if it's a new product, it's novel, and so it doesn't necessarily have a formal classification from the federal government. That doesn't mean it's still not illegal or that it's not problematic, but this is one of the things that some of these cartels, some of these drug dealers will do to create new products, just to try to keep detection, law enforcement on their toes, because not every assay, not every test will detect the same fentanyl. If you change it slightly, it'll detect certain things within range. And so there's dozens and dozens of different types of illicitly manufactured fentanyl that are out there. It comes in a couple different ways, primarily liquid and powder. And this is not to make a political statement at all, but it is right now, as far as what we know in the United States, it's primarily manufactured in Mexico and then smuggled into the U.S. Prior to that, and you all may remember news articles back, 3 years ago, where the government, the administration at the time, nationally really was putting pressure on China to clamp down on its labs from shipping fentanyl into the United States. And so, at the time, 3 or 4 years ago, we thought that China was where most of this was coming from. Now, what they've shifted to is not just Chinese labs, but labs from all around the world are making the raw materials, and then the raw materials are being shipped primarily to Mexico, where they're being reconstituted into fentanyl. The raw materials are not illegal. They're used in a variety of industrial applications. And so it's really hard to crack down on that because, again, it's like Sudafed and meth, with that, Sudafed by itself isn't illegal, and having Sudafed is it's used for lots of things. It's only when you have Sudafed and this, with lots of other things, your lithium-ion batteries and other different things, where you're talking like you got the precursors to methamphetamine. Same concept with fentanyl. When you have it all together, you obviously have something that's much different than individual components. It's also worth noting that these are not sophisticated labs that are making this. Okay, if you've seen, there's a great Wall Street Journal article, and probably for future slides, I ought to pull up some pictures from it, but it was some investigative journalism where they went to Mexico and actually talked with some of the folks that were down there that make this stuff for the cartels. And these are men and women making this in their garage, in a lean-to beside the house, under canopies, in 50-gallon drums. This is not sophisticated. This is not sterile compounding. This is very much what you can kind of imagine if you think of like the worst possible image of people out there just cooking drugs in a really shady sort of environment. And so that's what's happening. That's where it's coming from. And it's really hard to stop because, again, we're talking micrograms. So when you hear somebody has seized a kilogram of fentanyl, that is a ton, relatively speaking, of fentanyl as far as what it can be cut into and the amount of drugs that it can be spread throughout. And that's just 1 kilogram. We know that this is being made on a much larger scale than that across, hundreds, if not thousands of sites in Mexico and in other parts of the world. So when it's in powder form, it's going to look like a lot of other drugs. And what's happening and where this is problematic, and this is really important for those of you that are in recovery setting or that are working, with folks that are in active addiction, wherever you are, if you're encountering people that use drugs, and then even if you're not, this is where I also tell people, and if you know me, I'm not prone to speak in hyperbole or to exaggerate things or to fearmonger or peddle in that. But the reality is, when I was growing up, you could experiment with drugs and not necessarily worry about the first drug you tried killing you. Granted, I grew up in Just Say No and the DARE programs and all that. And so there was a lot of that fear mongering. That's one of the ways I've got kids, and one of the ways you try to keep them on the straight and narrow is you put a little bit of fear of God in them. With this, it is not an exaggeration to say with the current landscape of drugs that there is no safe way to experiment with drugs anymore. Especially things that you're buying off the street. I'm not talking about marijuana because that's still by and large, fentanyl is not in that. And we'll talk about that in a minute. But other drugs, we're seeing more and more that fentanyl is showing up, and it's showing up one of two ways. Either drug products are being adulterated with illicitly manufactured fentanyl, or they're being counterfeited outright. So what does that mean? In Kentucky, the drug of abuse, the drug of choice is still methamphetamine. And it has really been pretty much for the last 20 years in Kentucky. Meth is a stimulant. So is cocaine. That is not a depressant like what opioids are. And so what we're seeing, though, is that fentanyl is showing up in meth. It's showing up in cocaine. It's clearly showing up in heroin. As a matter of fact, I've been told by people in the harm reduction sphere and also by law enforcement that pretty much anything that is marketed as heroin right now on the street is in all likelihood fentanyl and not heroin. If you think about heroin, heroin's actually an agricultural product. This is just a side note, but just to help you all think through this a little bit. You grow poppy plants, and then those get further distilled into opium, and then that gets distilled into heroin. So at its core, heroin is an agricultural product. And so you have to worry about climate and maintaining crops and doing all that. Fentanyl is 100% synthetic. So again, once you have the raw materials, you're throwing it together in 50-gallon drums and cooking it up. So it's much cheaper and much easier to manufacture than heroin. And so what we're seeing, what I'm hearing on a national level, is that fentanyl is really supplanting heroin on a large scale across the country. So showing up in products where people don't expect it, it is still meth, but it's meth with fentanyl, or it is still cocaine, but it is cocaine with fentanyl. Sometimes this is accidental because if a drug dealer is, not cleaning their surfaces in between packaging things, you may get residue that just gets cross-contaminated. Sometimes it's intentional because people seek it out. They want fentanyl in their meth because it's, if you think back to I think it's 70s speedball, the idea of a speedball, an upper and a downer, a stimulant and a depressant together in one product. It's basically like the modern equivalent of a speedball. So the other product, and this is, I don't want to say that one's worse than the other. They're both really bad. The counterfeit products can almost be worse because a counterfeit product, somebody may not be thinking they're buying anything that has fentanyl in it. They're buying a Xanax on the street. They're buying an Adderall on the street. They're buying what they think is a Percocet 30, Perc 30, they call them oxycodone 30, or a Lortab on the street. That's what they think they're getting. The drug dealers and the cartels have gotten sophisticated enough that they can make tablets, the presses that they use, look exactly like the legitimate product. And to somebody that is not, a trained eye, and even to a trained eye at first glance, especially, it's going to look identical. It's going to be a bar with two score marks on it, like a Xanax, and it's going to be the same colors. And so what they're finding, though, is it doesn't have the product in it at all that they think they're getting. It's got talc and dyes and other inert ingredients, and then it's got fentanyl and Lord knows whatever else is in it. And so these are two of the things that are really driving the overdose death rates right now across the country. Ultimately, people don't know what's in there, and they don't have a tolerance to opioids, and it overwhelms their system, and that's where lead to overdoses. Now, this next slide, these are all headlines that I put this slide together today because I wanted to add this in here. This was 10, 15 minutes of me pulling up headlines, and I could have filled this entire screen with headlines. And this is all stuff that I suspect you've seen. Okay, I suspect that you all have heard this on social media. You've seen it in the news. You've seen it on Twitter. You've seen it everywhere. And I want to choose my words carefully here because I want you to understand that I don't believe that when law enforcement or when first responders or when anybody says that this stuff's happening, that they're doing it with ill intent. I truly believe that it is with best of intentions of trying to protect people. But the reality is medical professionals across the country have basically debunked all of this and have said this is not happening in the way that it's being purported. Okay. It is virtually impossible to overdose on fentanyl by touching it. You're not going to encounter enough of it through the air. It doesn't aerosolize, so you're not going to breathe it in. So these are all things that when you see reports like this, Resist the urge to share them on social media. Okay, just don't. Do all of us a favor and don't share these forward, because they're really, the vast majority of them are bad information. They are not accurate. And the problem is that nobody is going back and debunking this. People are debunking them, but the news sources are not going back and retracting or saying, hey, we got this wrong. This is a follow-up to the story that we reported a couple of days ago. There actually wasn't any fentanyl present. And so it just perpetuates this, this poor information. And this is problematic for a couple of reasons, okay? One is that there's already stigma out there with folks that use drugs, and there's already paranoia, and there's already concern, irrational concern about, am I going to be at risk when I help somebody if they've overdosed? Like, am I going to overdose if I help them? And you're not. Like, that's just not a likely thing. I don't want to say it's impossible, because I don't ever want to say anything's impossible, but it is not likely. This is a statistical zero for the most part that this would ever happen. And so we don't want to perpetuate stigma with people that use drugs, that they're somehow dangerous, inherently because they use drugs, because that's not the case. And also, especially for law enforcement, I want my friends in law enforcement to hear me that your job's already hard enough. You don't need to make it harder by having concerns that are not significant concerns. Your bigger risk is getting a needle stick because you put your hands someplace where you can't see and somebody has an uncapped syringe, and now you've got to deal with a biologic hazard. That's a very real risk, and that's one that I don't want anybody to have to go through. The risk of violence because it's, just drug-related activity, because maybe you're dealing with the dealers or cartels, that may be a significant risk, but the risk of coming into contact with fentanyl and overdosing is practically zero. Now, real quick, because it was mentioned before, I do want to mention vaping. I don't have a slide for this. Pretty much, well, I will just go ahead and say every report you've seen about somebody inhaling fentanyl with a vape is not accurate. For a couple of reasons. One, there's not been a single confirmed case where they've actually found fentanyl in a vape pen that's actually been used. Nothing that I've read. I've tried to follow up on as many as I can see, and I've never found a single lab confirmed instance where it's happened. One of the reasons is fentanyl boils at a really high temperature. It boils, sorry, I don't know if my accent made that hard to hear. So it boils around 850 degrees, and people don't vape that hot. Like, that is really hot to vape something. And I don't even know that commercial vape pens get that hot. So there's certainly theoretically possible that the molecule could attach itself onto something that is vaporized, but we've had no confirmed reports of that. What I am saying, there was recently a report that came out of Knox County, Kentucky, and it was a report on middle school kids vaping, and there was a note about presumptive fentanyl exposure. But when you look at what the symptoms were of the individuals, it was tachycardia. They were a little nauseous. They just didn't feel good. I was mentioning to the ladies earlier, if you've ever smoked a cigarette, if you've ever dipped, if you're of a certain age, or if you've ever worked in tobacco, nicotine poisoning is very real and is very easy to happen. And for especially kids, maybe experimenting with nicotine for the first time, you get too much nicotine in your system, and that's exactly what's going to happen. You're going to be tachycardic, you're going to be nauseous, you're not going to feel good. It's going to be a really bad experience for you. Another real concern with vaping is THC. Okay, CBD and THC. CBD is its own issues because of the oils. There's some talk about that several years ago. It could be unhealthy for the lungs because of the way it is actually in liquid. But THC is becoming more and more common as more and more places legalize recreational marijuana and really change just the market. And it's wide open. It's kind of the Wild West in the THC market. And I'm not saying this to poo-poo on THC or to try to fearmonger about that. I'm just trying to acknowledge that there are risks out there, because too high of a level of THC, if you get into super concentrated THC, that will also be a bad experience for you. I have a friend who is a regular marijuana user, and he's told me that he will not mess with edibles unless he's the one that makes them, because the worst experience he's ever had with marijuana with THC came from an edible that he didn't make, and it didn't affect him the way it normally does. It made him anxious and jittery and nauseous, and it was just not a good experience for him. And so what I believe, if we actually had testing done on these individuals, I think what we would see is high levels of nicotine in their body, or THC, not fentanyl. If a kid got into fentanyl in a vape, they wouldn't have tachycardia, they'd be dead. It would not be, tachycardia is an increased heart rate. It does the opposite. Fentanyl is a depressant. Opioids are a depressant. They slow the heart rate down. They slow breathing down, all of that. And so none of that is what's happening. And so I say that because I know schools in particular are getting questions about this. You all are probably getting questions if you're in the field, if you all are in professions that, people ask questions of. I feel confident in saying that that is not happening and that there are real risks to vaping. Vaping companies are absolutely marketing to kids, and it's problematic. It's not good. It can be a gateway drug to other things. Tobacco is probably more of a gateway drug than a lot of other drugs are, truth be told. And so just keep that in mind. This is kind of a public service announcement, but I felt strongly enough about it. You're not going to pick up a dollar bill and overdose. Okay. You're not going to pick up, you're not going to touch a tablet that's a fentanyl tablet and overdose. You're not going to get into a CBD gummy that has fentanyl in it in all likelihood, because there's no reason for those companies to do that. And again, once these things do get scrutinized, it's found very quickly that they're either were done with field tests, which are very insensitive and notorious, or they're so sensitive that they are notorious for false positives for a lot of things. And once lab testing that is much more specific gets involved, nothing is found in it. So that is what I'll say about that. I'm going to continue with fentanyl just because it is important for drug users. So this is the people that are succumbing to fentanyl are people that are using drugs, okay, that they're injecting them or ingesting them. And it's problematic because you're not going to be able to see, taste, or smell it. The only way to detect fentanyl in a drug is to use fentanyl test strips. This may be a new concept for you all. Some of you may not have ever heard of fentanyl test strips. If you have, good, I'm glad. I probably ought to introduce like a poll or something on this, just because it'd be interesting for me to know who does know about fentanyl test strips and who don't. But fentanyl test strips, if you've ever used a pH strip for, chemistry lab or for a diet, if you've ever, checked your pH of your body for dieting purposes, fentanyl test strips work very similarly. A person would use a little bit of their drug supply. They get it in solution, so they get some water with it, and then they dip the fentanyl test strip in there. And that fentanyl test strip is going to basically tell them positive or negative, yes, fentanyl is detected, or no, it is not. They are not perfect. If you remember a couple minutes ago, I mentioned that there are dozens and dozens of types of fentanyl out there that all have slight different variations on the chemical chain. And so the test strips, might test for 10 to 15 of them. But, if there's 25 to 30, they may not get those other ones. And so depending on what strain or what batch of fentanyl you have, it may not detect it. The idea behind fentanyl test strips, this is part of a greater concept of harm reduction. Hopefully that is not the first time you've heard the word harm reduction. Truthfully, we could do an entire presentation just on harm reduction. But harm reduction is just the idea that we know people are going to do things that may not be safe, that may not be wise for them to do or healthy for them to do. How do we as a society meet them where they are, mitigate the damage that they do to themselves, so try to minimize that, and then also try to minimize the damage or the harm that they do to society at large. So it's twofold, but it's ultimately just realizing that people can make decisions, and we have to meet them where they are and try to help them be safe and not die, because ultimately, when it comes to folks that use drugs, you can't treat a dead person. People that are dead can't recover. And so we know that people recover, so we want to give people the chance to do that. And so that's what harm reduction is about. Fentanyl test strips right now have been in the news a little bit. If you pay attention to the legislative session, we are currently, in Kentucky, they're considered paraphernalia. So that makes distributing them a little challenging for some groups. Right now, there's legislation working its way through that will remove the paraphernalia status from them. When that happens, then and it's by all accounts from what I'm hearing, it will pass. That will make it much easier. You could buy these in a pharmacy. You could walk in and the pharmacy would have them, and then you'll probably start seeing them pop up lots of other places, naloxone vending machines, other mobile events, things like that. So again, the idea there and where this could really be helpful is like, you all probably either heard stories or know college students or other students that, on the weekend, they might decide they want to try cocaine. They're not drug users. They don't routinely use drugs. They certainly don't struggle with a substance use disorder. They just want to try something. This also gives folks like that the option to test their product to make sure that it's not something that's got fentanyl in it, that's not going to kill them. So again, not passing any moral judgment or anything like that. Just know that that happens. How do we keep people safe? How do we, make sure that people can have fun, and not die. And I've mentioned, and this is the only time I'll mention it, but if you think about, depending on whether you may believe morally on that or otherwise, just think about alcohol and think about what it would be like if alcohol didn't have regulations or didn't have some safeguards in place. We saw this during Prohibition, where people, would die because they were drinking, the equivalent of antifreeze, because there was there's no rules about it, there's no regulations. People were making it and doing all kinds of crazy stuff. The same concept here. We want people to not die simply from a choice that they make that doesn't need to be a fatal choice. So we've already talked about this. I've already kind of gone over this, so I'm not going to belabor it. Just know that total exposure to illicitly manufactured fentanyl, especially for contact, is very unlikely to lead to any kind of an accidental overdose. You would have to come into contact with a fairly significant amount of it for you to absorb or to get a little bit of it in your system. So that's kind of where you just need to be thinking about this. If there's already a small amount to begin with, there's limited ways to get it in your system. So what I will tell any first responders on here or anybody else, be smart. Use common sense. If you are responding to somebody, or if you're in a situation where you think you might be handling drugs or product that you're not familiar with, wear gloves if you have them. Nitrile gloves are sufficient for pretty much the whole thing here. If you really are worried about breathing something in, not a real risk for that, but an N95 mask, or a K95 mask, even for that matter, but an N95 mask in particular, if it's fitted properly, is going to be more than sufficient to filter out anything you might come into contact with. And it's just not likely. So keep your hands out of your eyes, your mouth, and your nose for a number of reasons, but that's the biggest thing. If you handle money, know that money's gross. Money's got lots of germs on it. It's probably a good idea to wash your hands anytime you handle cash because there's lots of nastiness on that. So just wanted to, before we transition to what naloxone is, I wanted to mention this to you all, and then I want to pause as well to see if there's any questions on fentanyl, because like I said, this is the one topic where I feel like there may be some questions, and I want to make sure people are okay. Y'all have probably seen these numbers, but 2020 was a really bad year in Kentucky. It was bad nationwide just because there was, when we had the COVID-19 pandemic, everybody had a rough year, but it was really bad for people that use drugs. We saw in 2020 an almost 50% increase in overdose deaths from the previous year. So it was a lot. From 2020 to 21, we saw another 15% increase on top of that. So the numbers are continuing to go up. We're seeing more and more overdose deaths in Kentucky, and this is being driven almost exclusively by fentanyl. Fentanyl has been found in post-mortem when they do the toxicology screens. Fentanyl has been found in 2021 in 70% of overdose deaths. Now, it doesn't mean that fentanyl caused it, but it's highly likely that fentanyl is what caused that. So let me pause for a minute. Do we have any questions at all on fentanyl before I move forward?
We have a comment and a couple comments and questions. One person said, thank you for clarifying the sensationalism over accidental fentanyl overdoses with law enforcement and others. They've also seen the dollar bill thing floating around on Facebook. Someone else commented and said, when you asked the question about, are you familiar with fentanyl test strips? Someone said, I have some and used one on a client and it was positive. And the female argued it was meth and meth only.
Yeah. And that's, honestly, that's a situation where you got to do the best you can. If somebody, there may be a fear there that, somebody may not want to admit that it's there, or there may be some burying their head in the sand and not wanting to acknowledge the reality on the ground of what's there. So the best you can do is equip somebody with the information, and then, ultimately you can't force them either way. But we do hear reports that people have changed usage patterns with fentanyl test strips, either using, and that's the other thing I probably wasn't clear on this, a common sense sort of thing would be, well, if fentanyl's there, I'm not going to use it at all. And there are some people that would be that way. But with folks that use drugs, probably a more realistic approach is if they detect fentanyl in their supply, they may say, you know what, I'm going to use a test dose. Like if I normally use, whatever, an ml or whatever their dose of drug is, I'm going to push like a fifth of that in, like a very small amount just to see how I feel first. And so that's, again, harm reduction is a spectrum, and it's not an all or none sort of thing. If every little thing that somebody can do to be healthier or to be safer is part of that is harm reduction. So I saw that somebody raised their hand.
If whoever raised their hand wants to type the question in the Q&A, that would be great. We have another question that says, can anyone go to their local pharmacy and request Narcan? Does health insurance cover it? And do they track who's receiving it?
Gotcha. That one, we'll probably talk a little bit more about that. The short answer is yes. Most pharmacies will have the protocol in place to be able to distribute naloxone without you having to go see your doctor. Insurance does typically cover the generic nasal spray. Again, we'll kind of hit on that a little bit later. And there's also, I don't have a slide for it, but there's a copay program that the state has that I'll tell you all about at the end that will help cover it. And that's also part of our over-the-counter discussion. So good question, preview for what's to come here in a few minutes. I do see a question in here on fentanyl clustering and manufactured pills. What's the best way to test? That's a really difficult answer. If you're using pills and all you're doing is taking the pill, there's probably not a great way to test. The reality is any pill that you buy on the street, you need, if you are talking to folks that use drugs, that buy drugs, you just need to assume if you're buying it off the street, it has fentanyl in it. That's just the reality we live in now. So assume that it's there. Testing for it when it comes to pills is probably not necessary. The biggest issue with testing is in something like cocaine or meth, where often it is sold in powder form or in a form where you're going to snort it or inject it, because then you already are getting it down into a way that you're going to liquefy it. And so that's really probably the most common way. If you're buying pills, if it didn't come from a pharmacy and you didn't get it from a pharmacy out of the prescription bottle, you just need to assume it has fentanyl in it, full stop. And that's just what we tell people now. Somebody's got a question in here on another variation of fentanyl. Narcan doesn't revive. It's not fentanyl. What you're hearing about there is called Zalzine. That's one of the substances you're hearing about. There's others, but that's the most common one. It's also referred to as Trank. It is veterinary. There's a theme here, veterinary grade medication, and it is actually more akin to blood pressure medicines. So it by itself, I don't think is what's causing people to die, but the problem is it's causing people to get knocked out. When you put the two together, they become problematic because now it's really hard for somebody to breathe. Okay, and so, but that by itself, no, it does not respond to naloxone because it's not an opioid. So, so what you could have is you could reverse the opioid in somebody, but that still be on board and the person be unconscious. It's really problematic. It's problematic for a lot of reasons, but it's problematic in homeless population. One, because especially in the winter months, because if they are unconscious, even if they're breathing, if they can't be roused, they can very easily succumb to extreme temperatures. So hypothermia can be a real problem. And then the other issue we see with Trank is that it's causing all kinds of sores, and not even at the site of injection. Like people are breaking out in sores on random parts of their body. So if you work with people that use drugs, this is a telltale sign that maybe they're using drugs that have Zalzine in them or have the Trank in them. If you start seeing sores and they're like, that's not where I inject my drugs, I don't know what's happening, that may be what's going on, and that person probably needs to be referred or try to get them help with somebody for infectious disease, because abscesses can become problematic very quickly.
We have a question in the chat that says these strips are considered drug paraphernalia in Kentucky, so should we be advising folks to get those?
I don't know that that's a tricky question. My caveat with people is know your local law enforcement and what their proclivities are. Most law enforcement in Kentucky has come around to realizing that we're not arresting our way out of this, and some things they just turn their head on. And so I don't know that anybody is busting anybody for fentanyl test strips or confiscating them necessarily. However, when there's a larger issue, like when they've been arrested or when there's other crime going on, that may be something to build a case against somebody else. But just being in possession of them probably is not a big deal right now, even though that's what the law says. What I'm hearing, what I'm seeing is it's not a big deal. The biggest issue is being a paraphernalia law is prohibiting a lot of groups from giving them out that otherwise would give them out, because they legally just don't, they're not comfortable with doing that, because one, they don't want to get any of their clients or patients in trouble, and they don't want anything to blow back on themselves. So once it goes, and like I said, I'm 100% confident that this is going to pass, that it will not be considered paraphernalia by the end of this legislative session. And so it'll be a moot point. But for now, I would err on the side of caution. And if somebody is an active drug user, fentanyl test strips are one of the ways that they can be safer. And so I would be not as concerned about it being paraphernalia as being a life-saving tool for them. I'm looking at the Q&A in here too, Lee. I see cartels. I heard you mention cartels and drug dealers as responsible for the increase in opioid drug addiction. Not that they're increasing that they're responsible for that, but they are responsible for the increased fentanyl, which is definitely driving deaths. So wondering if you could speak on the medical community's role in increased opioid addiction, what safeguards you've seen put in place. This is probably more than we have time to get into today. There are lots of efforts around the state and around the country with regards to opioid stewardship. You may have heard that term. It's kind of like antibiotic stewardship. The idea is just how do we appropriately manage patients on opioids? How do we start them? How do we make sure we're using them when they are when they're good to use? How do we talk to patients when that's what they expect us to give them, but maybe that's not what actually is the best scenario for them? Maybe they need to be managed with non-steroidal anti-inflammatories, things like that. So there have been ongoing efforts. Prescription opioids have just about fallen off a cliff by comparison to what they were 10 years ago. They still are being prescribed, but we're seeing lots more hesitation. Now, that's one of the reasons I said at the beginning that opioids aren't bad. They are not inherently evil, because we're seeing the flip side happen now, where folks that have been on opioids chronically, and that have chronic pain, they're being denied care in some cases. And that's a dangerous place to be as well. If somebody has chronic pain and have been on opioids legitimately, they've not been somebody that's, used drugs, buying them off the street, but now all of a sudden they get cut off from their access to their legitimate opioid prescription. We do know that pushes people to use street drugs in some cases, if the worst case scenarios. And then even if it doesn't, you now have a person that is living with an intolerable amount of pain, and it's just a struggle. So that's a whole other presentation, to be really honest. But just know that, yes, there are things being done. There are efforts to try to do better with opioid prescribing, and to do better with just holistic view of medicine in general. Utilize PT, all that stuff. Let's see. On my caseload over the past 2 years, I've had 2 people order pills from the internet thinking they were one thing, but they contained fentanyl. Yeah. So that's, again, internet's a wonderful thing and a dangerous thing at the same time. Definitely something to be mindful of. Tell people it's not a good idea to buy pills over the internet. I think that covered everything. If I didn't cover it, put it in the chat again. We'll get it in a minute. I want to move on just for the sake of time. We're going to go a little faster with some of this. So naloxone, we just talked about opioids at length. Naloxone is basically the opposite of an opioid. Okay. It is a chemical that blocks the effects of opioids in the brain. So whereas opioids are agonist, naloxone is an antagonist. To use our same visual earlier, if we have the key in the ignition for the car, naloxone, when it comes into the body, it competitively wants to be on this receptor, meaning it wants to be there more than the opioid. So it will actually boot the opioid off, put itself there on the receptor. So it's basically like pulling the key out of the ignition, turning the car off. So when this happens, it stops all the things that are happening. So a person's pain relief, their euphoria, any of that gets stopped when naloxone is introduced. But most importantly, it helps them to start breathing again. So it is really ideal because there are several dosage forms. They're all easy to use. There are no drug interactions, okay? The only thing this does is it blocks the effects of an opioid in the body. This does not interact with any other drugs, and that's pretty significant because most drugs have interactions with other products. This is also really significant. It doesn't have any effect on other medical conditions or diseases, okay? Meaning you're not going to hurt somebody by giving them naloxone, all right? If they're having a heart attack and you give them naloxone, it's not going to make the heart attack worse. Know that you can't really mess it up. There is no max dose, okay? We don't know of any maximum dose, theoretical or otherwise, for naloxone, so you can't overdose them with it. It is not psychoactive. This is not a controlled substance. Even though it works on the opioid receptors, it is not a controlled substance, so it can't be abused. You don't get any euphoria from it, and it's safe in all ages. And I do mean all ages, babies all the way up to senior citizens and everybody in between. I don't have it on here, but it's also safe in pets. I mean, police in particular is significant for, because while humans aren't likely to overdose with contact, canines might, because canines experience the world through their nose. And so if a dog puts its nose right up on something that's got drugs in it and sniffs it in, it's going to have adverse effects of those drugs. And if fentanyl happens to be part of it, a dog could overdose. So a lot of law enforcement carry it for their canine units, which totally is understandable. It's safe for the dogs. There's very few side effects, and really the only significant ones are really rare. So they're not really worth discussing, because when faced with, death or possible side effects from naloxone, you're going to always give this naloxone. And the most important thing is it works. Okay, naloxone saves lives, full stop. Just know that. Okay, so we're going to transition here real quick. As far as who's at an increased risk for overdose, this really is kind of 2 large groups. folks that have overdosed before, and then people who have been abstinent for a period of time. So people that haven't used drugs for a while. This could be people that are in recovery, that are in treatment, that are trying to be sober. This could be folks that are incarcerated and are being abstinent against their will. They didn't choose to be abstinent, but because they're in jail, they may not have access to drugs. So if those folks, if they return to use, so if a person that is in recovery returns to use, if a person that is incarcerated and doesn't receive any kind of connection to care, and when they release, return to use, these are the highest risk for especially for fatal opioid overdose. And so this is a group that is really important to make sure they have naloxone or have access to it, or the people around them have naloxone. And then the last thing is anybody that, if there's certain medical conditions that could increase risk, particularly asthma or COPD, since we know not breathing is what ultimately kills somebody with an opioid overdose, liver or kidney disease, because that is where the drugs are processed through. HIV positive really has more to do with the fact that in Kentucky and in the United States as a whole, HIV is often a disease that is associated with people that have engaged in risky behaviors, specifically IV drug use. And so that's probably the bigger issue there. It's not that HIV itself has any high risk for opioid overdose, but the actual behaviors around a lot of HIV positive folks in the United States. So when we talk about reducing the risk of overdose, we really talk to two patient groups: folks that are using opioids pursuant to a prescription from a provider, and folks that are using opioids that are struggling with a substance use disorder, that are buying their opioids from the street or stealing or whatever they need to do. If you're using a prescription opioid, and this is something that you got from your doctor, it's important that you only take them as directed. You don't mix them with other drugs or alcohol. Particularly marijuana and benzodiazepines can be very dangerous to mix with opioids, because those are also central nervous system depressants. And when you put them all together, it just increases the risk that you're not going to be able to breathe. Okay. You also want to make sure that any healthcare providers know what you're taking, whether you're a caregiver for somebody that takes opioids, or whether it's you. Over-the-counter stuff can sometimes interact, vitamins and minerals. Other drugs can definitely interact with opioids. And so this is a plug for pharmacy as well. It's a really good idea to use the same pharmacy or the same pharmacy chain, because if you go to different pharmacies, and especially if you pay cash for some things, don't go through your insurance and some things, bill insurance and others, those systems, if they're not the same pharmacy or chain, don't always communicate with each other, depending on how, if it's billed as cash or insurance. And so pharmacists are really kind of the last line of defense for catching drug interactions that can be dangerous when it comes to opioids and other medications. So that's just a plug to use the same pharmacy. So folks that use drugs, though, and this is really probably the most important, because the reality is people that are overdosing on their pills they got from Walgreens is not what's driving the opioid epidemic and not what's driving deaths right now. People that are overdosing because of fentanyl in their supply chain and that use drugs and that struggle with substance use disorder, these are the folks that are driving the opioid overdose death rates. And so how do we reduce risk of overdose for them? We always tell folks, if you use drugs, it's best not to use alone. If you use alone and overdose, you can't administer naloxone to yourself. By the time you would even know that you need naloxone, you're gone. It's too late. And so don't use alone. If you have a reduced tolerance, so think back, mention if you're in recovery or if you are recently incarcerated and haven't used in a while and you return to use, start low and go slow. You have to assume fentanyl is in everything. But even if fentanyl isn't present, if it's just heroin or if it's an opioid, you can start to lose your tolerance, which is the amount of drug you can take and have the same effect that you had previously. That can start getting lower and lower with 24 to 48 hours of no use. And so if you've been in jail for a few weeks or a few days, even if you've been abstinent for a while, if you've been in recovery for a while, you cannot go back to using the dose of drug you were using before. So this is just, again, harm reduction. If you return to use, try not to have it be the last thing you do. Be smart about it, start low, go slow. And then if you have access to fentanyl test strips, test your product. Again, the idea is if you find fentanyl, you either won't use it or won't use the drug, or you'll use a lower dose. So I'm just going to throw these up here real quick. So what does an overdose look like? The biggest thing for you to keep in mind with an opioid overdose is somebody is going to be either really sleepy or unresponsive. They may or may not be breathing, and they may be breathing so shallowly that it looks like they're not breathing. But if they're not breathing at a minimal rate, they may not be breathing enough to sustain life. And so you're looking for somebody that is unresponsive, okay? The problem with unresponsiveness is that it also really and truly is pretty much every medical emergency, or a lot of medical emergencies result in unresponsiveness. A person could have had a heart attack or a stroke, or could be in a diabetic coma. It could also be unresponsive. Now, Think back to what I said just a few minutes ago. Naloxone does not interact with those diseases. So if you give somebody naloxone that is unresponsive, but they had a heart attack, you're not going to make it worse. Okay. So just know that naloxone is always okay to give if you suspect even a little bit that it could be an overdose. And if somebody is not able to be roused or woken up, then just assume that overdose is a very real possibility, especially here in Kentucky. Certainly something as obvious as drug paraphernalia. If you see a needle still in their arm or a needle on the ground or a baggie or something like that that looks like drugs, then that's a pretty good clue that that's what's happened as well. But you may not see that. These other things are just, again, signs and symptoms, but ultimately you are just looking for somebody that's unresponsive. We'll talk a little bit about this here in a minute, but when you try to wake somebody up, to gauge responsiveness, if you know their name, yell their name, shout their name, shake them if you can. If you know how to do a sternal rub, you can do that, but don't go crazy with the sternal rub, because you could hurt somebody if you really go a little too crazy on a sternal rub. That's just making knuckles and pressing really hard in the middle of their chest. I've heard some stories about people actually getting some scarring because they've had so many sternal rubs done and done aggressively. So may not be the best way to do it, but that's certainly the safest way. You don't want to dunk them in water. And I'm going to tell you this: if you hear patients or clients talk about slapping someone, sticking ice rectally or vaginally, not a good idea. It can hurt the person that way. Putting them in a shower, putting them in a bathtub, these are all not good ways to try to revive somebody, because there's risks of drowning and just other personal injury. So shaking them, shouting their name, doing a sternal rub, the same things, telling them, hey, I'm going to give you naloxone or I'm going to give you Narcan. Sometimes when somebody hears that, even if they're kind of unresponsive, that may be enough to kind of bring them out. I know it sounds crazy, but I've heard people report this. So these are just some things to keep in mind. Because I didn't have a great place to put this, I wanted to just very briefly go over naloxone law. I'm not an attorney, y'all, so know that right off the bat, but I have talked to enough people about this that I feel at least comfortable telling you about it. And the reality is, if you look at KRS 217186, it's really readable and it's super easy to understand. And ultimately what it says in a nutshell is basically all parties involved, if you've been trained and you're acting in good faith, you're not criminally or civilly liable for anything that happens with an opioid overdose reversal attempt. Okay. Now, where this gets a little tricky is when the person if you are calling as a Good Samaritan and you are involved with the person, you're using drugs with the person, you all overdosed or they've overdosed, you're with them, you gave them the drugs. It's still, I always tell people, err on the side of saving a life, even if you're worried about getting yourself in legal trouble, because the last thing you want is, an involuntary manslaughter or whatever, put on your record because you were involved with this person and you didn't seek to help them. Because in Kentucky, if you call for an overdose and report an overdose, you're not supposed to be hauled off to jail when police show up just because you did that, even if you were participating in doing the drugs. You may have your drugs confiscated. That actually might happen. But in Kentucky, you're not supposed to just be taken to jail. Now, that does not protect you if you have an outstanding warrant or if you're engaged in other criminal activity beyond just using drugs. And so this is just, it's a tricky conversation to have with folks that use drugs, but they need to know that they still need to err on the side of calling for help. You also need to make sure whether it's a person that's using drugs themselves calling, or if it's just a civilian, a citizen, make sure you tell dispatch, hey, we think this is an opioid overdose. It's too much to get into, honestly, but the Supreme Court a couple of years ago in Kentucky ruled that this needed to happen to give the person that you are calling about protections under the Good Samaritan law as well, just so they don't necessarily get involved in any further legal entanglements just because they had overdosed. So just know when you call 911, tell them we think this may be an overdose. That way everybody knows what to expect when they show up. Let me look real quick at the questions here. What is the draw of using Finnegan with opioids or benzos? Can you explain why opioids are both dilated and constricted people's categories? Different physiology there. I'll come back to the other one. Different people may respond differently as far as physiologically. I put that up there mostly as just an extra way to look, but I would never use somebody's eyes as a gauge. That's honestly going to be more of you can look at somebody's eyes often to tell if they are responsive and wake, maybe if they're under the influence of drugs, period. But if they're unconscious and responsive, you don't need to be trying to open their eyes to look at there. That's not my first response. Basically, assume that it's an overdose and act. And we're going to talk about this in a minute, but time is of the essence when you're responding to an overdose, because seconds without oxygen, minutes without oxygen can lead, even a person survives, can lead to brain damage. As far as Findergan with opioids and benzos, I don't know what the street issues would be there. Like, I don't know why somebody would choose to use it. I know Findergan is bundled with opioids, particularly with codeine as a cough suppressant, just because Findergan acts as an antihistamine and dries you up. And then the opioid, the codeine also can have some antitussive effects as well. I don't know. Again, I don't know. I've never had anybody say that they tried to abuse fentanyl and opioids together, other than just, or I'm sorry, fentanyl. I said fentanyl. I've never heard somebody say that they tried to abuse Findergan with opioids, other than it's a common preparation. You know, when I was in Louisville, people would often get promethazine DM, which is not promethazine with codeine. They would ask us to flavor it grape or put extra grape flavoring in. And I was told by some people, you know, that techs that actually had some street savvy, that they did that because they were going to go try to sell it as Findergan with codeine, because that's what it, you know, Findergan with codeine had a grape flavor. So that's, you know, I think it's just associated with the combination. There may be a reason they abuse it together, but I think it's mostly because historically they've been bundled together in prescription products. So that's my best guess. I don't know for sure on that, but that's just, if I had to guess, that's what I would guess. So when you're responding to an overdose, I have this slide. I want to mention this to you. This slide says to call 911, but I'm going to tell you all that we're actually changing the way I teach this. And I'm not updated this slide because I'm still discussing with some folks. But I actually think now that it is more important to administer naloxone first before you call 911. Again, because by the time you call 911, if you're waiting to get through, which, I mean, 911 is fast, but if you're waiting to get through to explain the situation, all that stuff before you start administering naloxone, that could be 10, 15, 20, 30 seconds, a minute or longer before you give the first dose of naloxone. And again, as I just mentioned, we're talking seconds in some cases here, because you don't know how long that person's been unconscious, or how long they've been unresponsive, or how long they've not been breathing at a level to sustain life. And so it's really important to give them the naloxone first and then call 911, because then that at least starts to let the naloxone work. And we'll talk about that here in a minute. But you want to put the person on their back. And if you know how to do rescue breathing, I'm not going to teach you how to do rescue breathing. That's a little beyond the scope of what I do here. I would hope that almost everybody has at least at some point had CPR training. And if they're not currently certified for CPR, they at least have had the training at some point. Where this is kind of a difficult thing now is if you've had CPR training done recently and you didn't have healthcare provider CPR, but you had, you know, just bystander CPR, they're teaching CPR now as mostly hands only or compressions only. And compressions are not what we're worried about with a person that's overdosed. Odds are they still have a pulse. It may be a faint pulse, but they probably still have a heart that's beating. They just don't have oxygenated blood. And that's the issue. And so breathing is what really becomes critical here. So again, I don't teach how to do this. This is just a very quick overview. You know, put the person on their back, tilt their chin up, open their airway. Don't blindly sweep their mouth to look for stuff, but do look to make sure they're not choking on something, obviously. Plug their nose, give 2 regular breaths, look for their chest to rise, not their stomach. If their stomach's rising, you need to reposition and go again, because if you start blowing into their stomach, it's a good way for them to throw up on you and on themselves, and to, you know, to have a whole host of other problems. We'll come back to rescue breathing in a minute, just as far as when you want to continue doing it. Just know that it is a very critical part of opioid overdose reversal, if you're comfortable doing so and if it's safe to do so. All right. So we're going to talk primarily about Narcan right now, but I am going to cover some of the other products here in a minute. Narcan just happens to be the most ubiquitous. Everybody knows what it is. That's what a box looks like. I am going to take my video off here in just a minute so that you all can see some of this. But when you open a box of Narcan, each box has 2 trays. Okay, and each tray has 1 dosing device in it. And when you peel that open, so this is where I'm going to go ahead and turn off my video so I can show you this. So all these devices, all the nasal sprays are going to look pretty similar to this. This is an old expired Narcan. The new ones actually have a red plunger like you're going to see here. When you open it up, each box has 2 of these in it. You're going to peel that back. Here's your device. And one of the things, if you don't remember anything else I'll tell you today, this is really important. This is where you hold it. This is where you put your thumb. This is not like other nasal sprays where you prime it. You've probably, if you've ever used saline or anything like that, or Flonase, you know, the pharmacist, the packaging will tell you, shake it up, prime it a couple times, get a mist. That's because those are multi-dose vials and you're going to use them over and over and over again. This is a 1-dose container. If you prime this, it's gone. If it's not in their nose and you push that plunger, that dose is wasted and it's not going to help anybody. So if you don't remember anything I tell you, Do not push this plunger. Notice that you can hold it left or right hand, so it's totally ambidextrous. There's no right or wrong way as far as that's concerned. Just, index finger, middle finger, and thumb on the plunger. If you're nervous, if you're shaking, you can always try to do it with 2 hands and, have one hand there. Just again, don't push the plunger in until you're ready to use it. You're just going to gently insert this in a person's nostril. Okay. You can see on me, I've got kind of fat fingers, and there's just a little nozzle there at the tip. That's all that needs to go in their nose. You do not need to put this entire nozzle in their nostril. If you do, it's going to go pretty far up, and it's going to be kind of unwieldy, and you could potentially like damage or, like scrape the side of their nose or, harm them in some way. The drug itself won't, but you don't want the device to harm it. So all you need is that little tip in their nostril. Once it's there, you're going to push the plunger. I'll show you what this looks like. I don't know if you can even see it on the camera, but when you push that plunger in, it just does a fine mist, comes out, and that's it. That's one dose. You want to step back and then just watch, give them some time, okay? It takes 2 to 3 minutes for Narcan to work. It could work faster than that, but in most cases, it's going to take 2 to 3 minutes. I'm fairly convinced that when you hear these reports of it taking 2, 3, 4, 5, 6 doses of Narcan to revive somebody, that probably what happened, not always, probably what happened is a person had 2 or 3 boxes of Narcan and they hit them with one, and then 15 seconds later, they hit them again, and then 15 seconds later, they hit, and they kept just boom, 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 boom. Because when a person is laying there not breathing, that's really stressful, especially if it's a loved one. You're freaking out, you're panicking, you want them awake. So this is just kind of a best practice thing. You do want to give it some time to work, but know that if you panic or if you give multiple doses back to back like that in rapid fire, again, you're not harming the individual. The naloxone itself is not going to harm them. And ultimately, we'd rather restore breathing quickly. So, it's whatever you're comfortable doing. If you're comfortable waiting, letting it work a little bit. One of the reasons why you want to do that is because I'm a big advocate of lowest effective dose of any product. You can't give too much Narcan, but the more naloxone you administer to somebody, especially somebody that uses drugs regularly and has a really high tolerance, you could be precipitating a much more extreme withdrawal for them. We'll talk about that in just a minute. But you want to kind of step back, watch them. This is, again, a good time. If you've not called 911 yet, go ahead and call them after the first dose you give. And then after the 2 to 3 minutes, if they're still not breathing, you want to repeat that same cycle in the other nostril and just alternate nostrils every 2 to 3 minutes. After every 2 doses of naloxone, it's a really good idea to do 2 rescue breaths. Again, if you're doing it as proscribed here, it's going to take 2 to 3 minutes between doses, so 4 to 6 minutes between 2 doses. That's 4 to 6 minutes that the person may or may not be breathing or getting oxygen. So give 2 rescue breaths after every 2 doses of naloxone. Know that if you run out of naloxone, rescue breathing is all you can do to help support them, okay? You can continue the cycle, though, until they are awake or until the overdose is clearly reversed and they're breathing on their own. They may or may not be up talking, but if you can clearly see that they're breathing now, then you probably don't need to continue administering naloxone. You can just stay with them until EMS shows up. If you run out, again, just do rescue breathing, or if EMS shows up and they're still unconscious, hand it off to EMS. They can either use more naloxone, more Narcan, or they may have injectable to try to titrate a person out. They can also do intubating or breathing bags, things like that. If a person does come to, but they're not fully awake, they're not like sitting up talking to you, you want to roll them on their side, put them in the recovery position, which should be somewhat familiar to you if you've had CPR training. A couple reasons for this. One, it facilitates breathing, but also nausea and vomiting are really common with an overdose reversal. You do not want the person on their back, throwing up, aspirating it, choking on it, getting in their lungs. That just creates a whole host of problems for that person. You do need to be prepared for a person to be combative or agitated when they're revived. However, a lot of times people are like, well, they're in withdrawal. You took their high away from them. That's what's causing it. And honestly, yes, that's possible, but a more likely explanation is depending on how long this person's gone without oxygen, they have an anoxic brain injury. When your brain loses oxygen, people that have had a lot of lack of oxygen often wake up disoriented, aggressive, violent. And so that's much more consistent there. Somebody that's going through withdrawal is honestly probably going to be curled in the fetal position and not be real happy. So that, yes, it could make them agitated, but again, this is why time is of the essence. It's really more important to get them oxygenated, because we don't want to cause their brain injury. Because even if the person survives, if they have a chronic, like a severe enough brain injury, it could really impact their quality of life moving forward. So they will be put into withdrawal, though, in an almost immediate state of withdrawal. And this is why I kind of recommend using the lowest amount of effective naloxone as possible, because this is going to be a really unpleasant experience for a person. And what you may do when you have all these things hit you at once is you may push a person to use more quickly. So they may go back to using because they, if you talk to folks that use drugs long enough, a lot of times it's not even about getting high anymore. It's about not getting sick and being able to function. Dope sickness is a miserable experience for people that use drugs, and they're terrified of it because it's just awful. They're going to feel like they're dying if they're in withdrawal. The good news is withdrawal is not life-threatening unless somebody has already got, dehydration and some other severe, serious issues and are vomiting and diarrhea. Then you can have some issues, but just by itself, it's unpleasant, but it is not life-threatening. Now that is opioid withdrawal. Alcohol withdrawal, different creature. That's a different beast. You do have to treat people with alcohol withdrawal medically because that can be very dangerous for them. Understand that naloxone will wear off. Only lasts, anywhere from 45 minutes to an hour and a half. And this is going to vary depending on a person's physiology. It's also going to vary depending on what's in the person's system, depending on the opioid that's in their system. I didn't really mention this, but it does bear mentioning that naloxone does not remove the drug from a person's system. It's still there circulating around in their brain and their bloodstream. All it does is block it from working. Once the naloxone wears off, and once it's no longer doing its thing, those opioid molecules are going to go right back to the receptors. And if the body hasn't processed enough of them and cleared enough of them, a person could go right back into an overdose state. If they are in bad enough withdrawal that they go back to use, they go find more drugs, they could get more drugs in the same batch that have fentanyl in it or whatever, and they could just overdose again. And the next time possibly not have somebody with them. So this is why, again, don't stress about this. Give them as much naloxone as you need to revive them. But if you are in a controlled situation, if you can, help them with breathing, if you know how to use a bag and you've got one to help them breathe, or if you can do mouth to mouth and help them breathe, just try to use the lowest amount of naloxone that will help actually revive them. Somebody says here, if a certain amount of time when somebody has been unresponsive, that Narcan would not be administered or not effective. So, I would leave that determination to a trained medical professional, an EMT or paramedic. If it's me responding, unless the person is blue and cold, like clearly they're gone, I would give them naloxone because we can replace naloxone. If it doesn't work, it doesn't work. I will say if you've given 2 or 3 doses of naloxone and you're not seeing a response, keep giving it if you got it, but at that point, you definitely need to be focusing on breathing and trying to get breathing for them. I've heard stories of EMS showing up to a scene, and because they are trained, they have to use they don't have unlimited resources. And if somebody is gone, if they know that this person is deceased, and they know that it doesn't matter if they throw a truckload of Narcan at them, it's not going to do anything. It would just waste the product. They may make that call. But as a bystander myself, who doesn't necessarily have that training, and especially if it's my loved one or somebody I know, I'm going to keep throwing every bit of naloxone at them I have, and I'll let EMS make that call ultimately. I've heard some pretty miraculous stories of people that looked like they were gone and naloxone's brought them back. So that's not an easy answer. Just know that if you got it, give it. Probably if that helps. So we're going to go through this last bit, the next couple slides fairly quickly, because this is really just going over Narcan and then another form called Cloxado. Narcan is the product that most people are familiar with. Naloxone as an entity has been around since the late 60s, early 70s. So the chemical is old and it is very well studied, very safe. We know lots about it. Narcan didn't come on the market until 2015. Its claim to fame is it was the first nasal formulation, nasal delivery system approved by the FDA. If you've been around long enough, you probably have seen the little device you screw on the end of pre-filled syringes and then use that, and it aerosolizes or makes instead of being a stream of liquid, it makes it a mist. Those worked great and they were wonderful until Narcan came along, but it was an extra step, a couple different products, and so Narcan has just really made it super easy. There are now generics available. They came around, it lost its patent really early, so Narcan actually went off patent. It came out in 2005. Usually it would last much longer, but it went off patent like a year or two ago, and so there are multiple generics available now, and it is going to go over the counter, and we're going to talk about that here at one of our last slides. It is going to go over the counter probably later this month when they'll make the determination. The storage and handling that I'm going to talk about, really these apply to all the naloxone products we'll talk about. Ideally, you want to keep it at room temperature. However, the manufacturer has tested it at extreme temperatures on both ends, both really cold and really hot, and they've even frozen it and thawed it multiple times, and it does not seem to affect the stability or the efficacy of the drug. That's important. In Kentucky, spring in Kentucky, you all seen it in the last week, will go from 70 to 30 sometimes in the same weekend. So if you leave this in your vehicle Best practice is to leave it on your person or in a bag that you carry with you or something like that. But if you leave it in your vehicle, that's okay. Just know that if it is frozen, if it's below freezing, you can't use it while it's frozen. It's not going to do any good. You have to wait till it thaws, and that, it won't take long. But again, in this moment, this is not a calm moment in most cases. You're going to be panicking. So not a good idea to leave it when it's going to be freezing. If you do leave it out in the summer, you just don't want to leave it in direct sunlight. So don't leave it in your seat or on your dashboard, in your glove box, center console, under the seat, in the trunk, probably be better. But again, purse, satchel, backpack, fanny pack, whatever you carry. If you take it out of the box, that's okay, but you don't want to take it out of the tray. And if you do take it out of the box, I will just show this. Leave it in this tray. You want to put it. Don't peel the foil back. Leave it in a tray. Put it down in a zip top bag or something if you're to take it out of the box. If you carry it, that is not recommended. But I know a lot of organizations that repackage it that way before they give it out anyway. That's okay to do. Not going to hurt anything. You do want to, again, protect it from sunlight, and then you want to replace it before it expires. Now, understand that expired Narcan is better than no Narcan. And truth be told, expired Narcan is probably going to be just as effective as current Narcan. There was actually a study done a couple of years ago with naloxone, not Narcan specifically, which is the brand name of the nasal, but just vials of naloxone that they'd gotten from a fire department. It was 30 years old. They tested all of them, and every single lot was at least still 90% effective. I don't know that the plastic containers that hold the nasal spray will hold up that long, but know that for most of us, we're not going to have Narcan for 30 years. If it's a couple of years expired, let that remind you to go get a new one. But hang on to that expired, because if you need multiple doses, that's going to be just as helpful, to have, and better than nothing. Right. We've talked about the safety stuff. It's safe to use in everybody. Person doesn't have to be breathing. This is sometimes a misconception that people have. You don't have to breathe in somebody's nose, like, cover their nose and breathe into it once you administer it. It absorbs through the mucosal membrane. It does not go to their lungs, right? I've talked about these things. This is what the most common side effects are. Again, this is also a very likely result of removing the naloxone itself, or I'm sorry, removing the drug itself from the system. So this is kind of what withdrawal looks like for people. Kind of run through this. So Kloxxado is another product you may have heard about. It's an 8 milligram spray. So think of it like extra strength Narcan. I'm sure they would love to hear me say that, but that's essentially what it is. It's double the strength of Narcan. But if this device looks familiar here, it's identical to Narcan. All these companies use the same, they license the same device from a company, I think it's a Swiss company. So I'm not going to show you how to use this, because everything that I showed you with Narcan applies to this. They all work exactly the same, every 2 to 3 minutes, repeating the opposite nostril, all that applies here. Also, the same storage and handling stuff we just mentioned applies here. Okay. This was super easy. It's just know that it's out there. You may see it. I'm kind of agnostic on it. I don't know that I believe we need higher doses of naloxone, but I don't think they're inherently bad. Just know that if it's there, if you ever run across it, it's easy to use. It's just like the Narcan. I am going to pause for a minute here and show you how to use this, because this is a different product. Still easy to use, but it is different. It's called Zimhigh. If you see this, again, it's starting to show up. It's only been out for about a year. But it is starting to gain some traction. This is the highest dose naloxone product that's on the market right now. I know Kloxxado is 8 milligrams, but very quick lesson in pharmacology and pharmacokinetics. Nasal delivery systems and injections have different bioavailability, meaning they get absorbed at different rates and different thoroughness or levels in the body. Injections get absorbed much higher. They're faster, not necessarily like minutes faster, but they are faster, and they get absorbed at much higher rates. So an injection is going to be absorbed anywhere from 75 to 100% fully in the body to be used. A nasal spray, 20% may be a good high end of what might actually be absorbed. So even though it's 8 milligrams, you may only absorb 1.6 to 2 milligrams of the active drug to use. Whereas when you administer 5 milligrams of Zimhigh, you're going to get 4 to 5 milligrams in the bloodstream. So this is a lot. Again, it's not, you can't overdose somebody on it, but just know that you're probably not going to need more than one of these if you do use them. And you will almost certainly, if they're going to go in withdrawal, you're probably going to put them in withdrawal from this. Not a bad product. Actually, one of the things I like about this, and they've kind of won in form factor, it comes in a box. And when you take the box out, there's 2 of these containers. They're hard plastic containers. They snap apart. And then there is a little lip here. And when you open it up, This is a trainer, so the real device would actually be bright red here. You can see it in the picture there. When you open it up, you take it out, and then let's see here. So when you take it out, so you're gonna, the company has like press, push, pull, place. They've got 4 Ps, but when you hold it on the end here, there is a cap that you would twist off. On the real device, there's a little window here. You look at it. If you've ever used insulin or any other injection, they always tell you look at it, make sure it's not cloudy. You can hold it up to light, and as long as everything looks clear, you should be fine. But you'll twist off the cap. This, you can probably see, this needle probably looks huge to you all. One, because it's got a ball in the end. This is, again, a demo device. But once it's there, you're going to hold it in between your index finger and just basically any way that's comfortable, but keep your fingers away from the actual the sharp point. And this is going to go on their thigh, and it goes through clothing. Okay, so it goes right through their jeans if they're wearing them, like in their arm. You could do, I'm just going to show you, pretend this is their thigh. Goes in, you push the plunger, hold it for 2 seconds, take it out. That's the dose. Cover your needle. Now you're good. Okay. Put it back in the box, just like this. And then again, same stuff applies. Store at room temperature. Don't refrigerate it. Don't freeze it. I don't know if this freezes. They're both really small volumes, but it could potentially damage a product. So I would definitely try not to freeze the Zimhigh product. Again, it's out there. It's available. Nalmefene, I only mention because it's out there. It is an opioid antagonist. It's the reason why, if you look at all of our legislation, our statutes, we've changed it to say from naloxone to say Nalmefene, or I'm saying to say opioid antagonist, because it does exactly what naloxone does, but it is not a naloxone product. It is an opioid antagonist. It's primarily only used in hospitals. I don't anticipate this being available to the public anytime soon, but it might. Keep it in mind. I'm not going to dwell on that because we already talked about it. Real quick discussion on over-the-counter. This is in the news. People are hearing about this. A month ago, February 15th, the FDA Advisory Council voted 19-0 to say, hey, FDA, we think you should make naloxone over-the-counter. What this applies to is 4 milligram sprays and 2 milligram auto injectors. Nobody's making the 2 milligram auto injector anymore, so that's kind of irrelevant, but you may see or hear that in the news. But the 4 milligram nasal spray is pertinent. That's Narcan and all of its generics. There is also another product that's coming out that is a 3 milligram dose, not a 4 milligram dose, and it's going to have the exact same dosing device as this. It's going to be a 2-pack, and that company has already said it's going to be around $36 for both, for $18 a dose, $36 for 2. We do not yet have pricing on what the Narcan is going to be. My best guess is that it'll be competitive, so I'm hoping $30 to $36. I don't know when we're going to see it on the shelf. 29th of March is when the FDA is supposed to give its formal, yes, we think Narcan should go over the counter. But just what I know about products, unless Emergent Biosolutions, which is the company that makes it, unless they've already got this stuff ready to go, I think we're looking at early summer before we see anything on the shelf that you can buy. And I think that, we're still going to have like a twilight period where there's still going to be prescription products out there and the OTC. Where this is going to change things, somebody mentioned this earlier in the chat. Once it goes OTC, I do not expect insurance companies to cover it anymore, to be honest. Most insurance companies, most commercial plans do not cover OTC products. I do think Medicaid will continue to cover it. They've already indicated they will continue to cover it. And so that's a significant, that's 30% of Kentuckians basically is Medicaid. So they will be covered. This does bring me, and I don't have a slide for this, and I apologize because I realized I should have put a slide in. We do have a prescription copay program in the state of Kentucky. And let me see if I'm going to type this in here just so you all have it. And you all can go look at this. Second. Hopefully that should work. You all can go and click on that and go to it. What this is grant funded. It's with the core grant. This will cover for people with commercial plans. This will pay right now up to $60 of a commercial plan copay. We're probably going to lower that because honestly, the prices are coming down. Now the generics and most insurances are covering it. Copays are typically much less than $40, and we're going to see the prices drop. So we will probably drop that total reimbursement rate to a lower number. But what that means is that people with commercial insurance, if cost is still a barrier, if they've got a $10, $15, $20 copay, and they're like, I don't know if I want to pay that, this will basically act, if you've ever billed any kind of a coupon, take it to your pharmacy, the pharmacist bills your insurance and they bill the leftover to this, and you get either a no copay, $0, or very, very low amount, depending what your original copay was. We're going to add, the plan right now is once we get details on it, we're going to add the over-the-counter products to this. So this will kind of become a de facto coupon for that. That's our current plan. So we hope that will increase access. My hope with over-the-counter naloxone is that it mostly just increases access for people not being hesitant to give out naloxone because they're worried about the legal entanglements around the prescription status. The website that I just put in the chat for anybody that's listening is that site. I will show you here the magic of the internet. So this is what it looks like. The good news about this program is it does not require a patient to register for anything. When you click on any of these printable documents over here, these are all, every single person will have the same ID. You don't have to sign up for anything. You're not going to get emails from us. We're not going to reach out to you. The only data we see on the back end is a patient's age, gender, and the zip code that their pharmacy was in. That's all we see. So there's no way we can, connect this to an individual. So we don't want it to be a barrier. We don't want it to be something that's, I see it here. It says host and panelist. Somebody's put that in there. I apologize. Let me put it back through. I apologize. There you go. Now everyone can see that. All right. But yeah, this just gives some information on it. Again, very straightforward. We don't want it to be a barrier to access. These things are things you can print out. You can also ask your pharmacy about it. We've mailed out information to almost every pharmacy in the state, so they should at least have heard of it. But these are just some resources there. So that's out there. That's a program that exists. We're going to continue this for the foreseeable future with grant funding. So that brings me to the end of my session. I know we've got a few minutes left. I don't know if you'll have questions, comments, concerns.
We do have a question in the chat box. Someone asked, well, we have two. How long after a person takes the overdose amount does a person go into overdose?
So that really varies. That's going to vary wildly. This is where we're starting to see issues with people that use drugs recreationally. So somebody snorts a line of cocaine at a party, a college kid, and that's the only drug they've ever done. If it's got fentanyl in it, they have no tolerance to an opioid at all because they don't use opioids. They're probably going to succumb pretty quickly because they have no tolerance. Now, I've heard stories about people that use drugs regularly, and when they're using IV drugs and they're injecting, I've heard stories about them being found with a needle still in their arm because it had enough fentanyl in it. By the time they got done pushing the drug, it went to their brain and they overdosed immediately. So it's just going to vary. A person could be awake and nodding off and non-responsive, but on their way to an overdose as the drug starts to work more and more in their body. So there's not a specific time. It can happen almost instantly, or it could be over a matter of minutes or hours theoretically, but probably pretty quick.
What do you know about the new medication for fentanyl overdoses? The person says, I believe it must be injected.
The only thing that's out there is what we already have. That's maybe the nalmefene that they're talking about. That's it is available in hospitals. It's not better than Narcan or naloxone. It's just a little different. I think the biggest claim to fame of it is it lasts a little longer in the system, but I've not heard of any new product that's out there that's not naloxone at this point.
Someone asked in Q&A, where can you get Narcan? I was trained to use and received one, but had to use it. Do you need to go through the training again to get more?
So depending on where you are, there are lots and lots of entities around the state that are distributing it. Any health department in the state of Kentucky that has a syringe service program will also have naloxone. So you can go there for sure. They will give it out to people in the public as well, not just the syringe service patients. I'm going to put another link in here. So this is another website. It's called Next Distro. This is a nationwide site. However, Kentucky has a partnership with them, specifically Kentucky Harm Reduction Coalition. They are, if you don't know anything about Kentucky Harm Reduction Coalition, they're a great group out of Louisville. They do wonderful work engaging with folks that are in active addiction, that struggle, meet people where they are, providing services, providing connection to care. but they also are part of, they receive funds from CORE, and then I supply them from naloxone. They do a mail, basically you can request it via the mail through their website. They'll mail you a dose. You can also get fentanyl test strips from them as well. Again, when it goes OTC, I'm hoping that just makes it even more ubiquitous and easier to find. I don't think it's going to be cheap. It's still going to be a little pricey, but it should be much easier. But you can always go to pretty much any pharmacy and tell them, hey, I'd like to get naloxone. They can bill your insurance. Unless you're with the copay program, it'll be cheap. There are a bunch of jails. There's a comment in here. We just actually 2 weeks ago started a program with Van Ingram and Office of Drug Control Policy, where we've supplied 20 jails around the state with naloxone to give out to inmates. And this is not inmates that are struggling with OUD necessarily or substance disorder. This is every inmate. If they are willing to take it, they can take naloxone with them when they leave. Because odds are, even if they're not using drugs, they probably know somebody that is, or have a loved one or family member or somebody that is struggling. And so again, we're really trying to, Sam's just trying to saturate the state with naloxone. We're really within that trying to focus on people that have witness overdoses. Like those are the ones that really need to have it, because I could carry it all day long, but if I don't see somebody that overdoses, I'd use it. But if I just don't come into contact with those folks, it's good intention. So this is the idea of putting it in the hands of people that are actually going to be able to use it and get it to folks. You are going to see and hear Narcan vending machines are a hot topic right now. I'm not a huge fan, not because I don't think they're good, but I think there's better ways to get it out there. I like Nalox boxes in particular, which are much more targeted, smaller devices that have maybe 4 or 5 boxes of Narcan in them, at gas stations or libraries or places that are very strategic, but not necessarily a huge vending machine. They're a little more effort to maintain, but I think those are sometimes a little bit better from a targeted perspective. But anybody else? Anything else?
I think that was our last question. I just want to say thank you for joining us today. We had over 200 people with us this afternoon. So a lot of people heard this information. And again, thank you for taking the time to be here with us today.